Here is a detailed explanation of membranous nephropathy, MN, focusing on the pathophysiology, step-by-step, treatment options, and prevention. Introduction. Membranous nephropathy, MN, is a common cause of nephrotic syndrome in adults and is characterized by immune complex deposition on the outer subepithelial surface of the glomerular basement membrane, GBM. This leads to glomerular capillary wall thickening and proteinuria. Pathophysiology, step-by-step process. HO1 triggering event. Primary, idiopathic, autoimmune origin, most commonly due to autoantibodies against podocyte antigens, especially PLA2R, phospholipase A2 receptor. Secondary, triggered by infections, e.g. hepatitis B, C, malignancies, autoimmune diseases, SLE, or drugs, NSAIDs, gold salts, penicillamine. Not 2. Autoantibody formation. In primary MN, IgG4 autoantibodies are formed against PLA2R or THSD7A antigens present on the surface of podocytes. 3. Immune complex formation. Antigen-antibody complexes form in situ at subepithelial space of the glomerular capillary wall beneath the podocytes. In secondary MN, circulating immune complexes may deposit instead. 4. Complement activation. Complement system, especially the membrane attack complex, MAC, C5b9, is activated. This leads to inflammation and damage to the podocytes in GBM. 5. Podocyte injury. MAC causes podocyte effacement, disrupting the filtration barrier. This results in increased glomerular permeability 6 proteinuria. As a result of barrier damage, large amounts of protein, especially albumin, are lost in urine, nephrotic-range proteinuria. 7. GBM thickening and structural changes. The GBM thicks through the deposition of immune complexes and new matrix material. On light microscopy, spikes may be seen with silver stain. Treatment options. 1. Supportive therapy. Blood pressure control, ACE inhibitors or ARBs to reduce proteinuria, salt restriction and diuretics for edema, statins for hyperlipidemia. Anticoagulation may be considered for thrombotic risk in nephrotic syndrome. 2. Immunosuppressive therapy indicated in moderate to severe or persistent proteinuria or declining kidney function. First line, anti-CD20 monoclonal antibody, increasingly preferred due to fewer side effects. Alternatives, cyclophosphamide plus steroids, Ponticelli regimen, effective but more toxic. Calcineurin inhibitors, e.g. cyclosporine or tacrolimus. Treat underlying cause. For secondary MN, manage the underlying condition. Stop offending drugs. Treat infections, e.g. antivirals for hepatitis B. Manage cancers or autoimmune disorders. Primary MN, idiopathic. No definitive prevention due to autoimmune origin. Genetic and environmental risk modification under investigation. Secondary MN, avoid known offending drugs, e.g. NSAIDs, gold, penicillamine. Early detection and treatment of infections, e.g. hepatitis B, C. Regular cancer screening in high-risk populations. Control autoimmune diseases like SLE. Summary table. Description of infections, C. NAMP trigger. Autoantibodies, PLA2R, or external antigens, infection, drugs, tumors. Immune complex deposition, subepithelial immune complexes form. Complement activation, MAC damages podocytes, podocyte injury, loss of slit diaphragm, protein leakage. Clinical outcome, nephrotic syndrome, proteinuria, edema, hypoalbuminemia, hyperlipidemia. Treatment, supportive, immunosuppressive, and disease-specific therapies. Prevention depends on primary versus secondary cause. Thank you. Have a nice day.